Hello.
Hello, sir.
Morning.
Hi.
Hi, good morning,
I
everyone.
think my video is not on.
Oh.
Hello, Professor V.
Hi.
Hi, how are you? It's
Dr.
what
Tuesday.
time is it there?
I'm sorry?
What time is it there?
Oh, it's in the morning. It's now 8:20.
Okay, okay. Thank you so much for coming and for this program. This is actually a program where we are trying to encourage young plastic surgeons to come and present their passionate work.
Wonderful. Wonderful. It's my honor. Thank you for inviting me.
We are honored. We are honored to have you. We'll wait for about 10 minutes. We've got 10 minutes for it to become 6. Good evening, Ramani.
Good evening, sir. Good evening.
How you doing?
Thank you, Prof, for accepting.
How is your routine, Professor?
My routine for
Hospital?
For hospital. So we've been back to full capacity since I think that was in the second half of April. So we were for a while we were restricted to just emergency surgery and cancer reconstruction, and but since April we were back to normal. Well, not normal, but back to full capacity, including elective surgery. Yeah, so now it's quite busy.
How do you screen your patients? What basic test do you do before you operate?
So our policy changed several times until we finalize what we're doing right now. So for patient visiting our clinic for just consultation, we don't require COVID testing. But once we are ready to take the patient to the operating room because of intubation, I mean, that is a time of higher risk of viral spread. So we do require COVID testing, the confirmatory testing, not the screening test for patients who are going to the operating room. So that's how we do it. And everybody goes into the hospital, gets a temperature check and travel history and all that.
And what does your work mainly consist of? Microsurgery or the regular hand?
So my practice consisted, focuses on microsurgery and super microsurgery, and I don't have a particular body part. I go from head to toe. Hand is not my focus, and right now about nearly half of my practice is focusing on lymphedema.
Good, that's good. I think it's a very upcoming field, lymphedema surgery.
Sure. Sure.
And we are very curious about it. We want to learn a lot about it because we have, I think one of your Facebook discussions was on this. Somebody had asked, where is the lymphedema in that patient where you had marked the lymphatic vessels? And you had said that it is not so obvious like you have in other countries, the lymphedema. Just an increase in the size of the limb is enough to indicate a surgery, isn't it, in your part of the world?
Increasing size of the lymph.
Because here we see very grotesque deformity.
Oh, yes. I got it. So the treatment of lymphedema has evolved rapidly lymphedema surgery has evolved rapidly. So not too long ago, everybody was saying lymphedema is not treatable, which we realized actually since 1990, Professor Hanqi Chan started doing lymph node transfer. We knew already lymphedema was treatable. But for a long time, we've been saying that lymphedema is not curable. Lymphedema is treatable, but not curable. Just like diabetes, we can't cure diabetes, but it's fine. Take the medication and you're fine. But in the past, actually, we've been seeing the cases of cure for a while now. So recently we came out and said lymphedema is curable. We need to aim to cure. So we started to look at what are the characteristics of patients who we cure. Well, the fact is we are curing only a small percentage of patients. In a retrospective review that we're about to put out that looked at 2 years worth of our LVA patients, we found that the cure rate was 16%. And we found out that all 16%, well, not all, but majority. So what's common in this patient population is they have reversible swelling, meaning at times their leg could look normal. So for those patients, we treat with curative intent. Of course, we probably don't see elephantiasis as I've heard some of the Indian surgeons mentioning that you see quite a bit of elephantiasis. We don't see elephantiasis as frequently, but we also do see many patients with advanced disease. So the treatment goals are different for those patients. So those patients, unfortunately, we've missed the opportunity to treat. So for those patients, it's not realistic to expect to cure them. Given current technology, we're still working on advancing what we do, but they can still be effectively managed, just probably not cured at this time.
So I think you are treating it something along the lines of early cancer, which is curable almost curable, and late advanced cancer, which you can only do a palliative surgery. It's something like that, akin to that, isn't it?
Right, right. Although palliative, I think in terms of meaning adequately describes it, but we prefer to think of those as managing a chronic condition. So lymphedema has become a condition that we can effectively manage to stop disease progression and to bring about various extent of disease reversal. And the sooner the patient presents, the better. So we've also modified our paradigm. In the past, we always said surgery is second-line treatment. Lymphedema therapy is first line. We no longer say that anymore. Now we say therapy and surgery are two different treatment options with different pros and cons. And so our therapist would co-evaluate the patient with us, and we talk to the patient about both treatment. For some patients, they don't want surgery. I mean, your treatment strategy for someone who's 80-year-old versus a 20-year-old could be quite different. A 20-year-old would be willing to put up a basic procedure, and they want a more fundamental treatment. Yeah.
It was nice talking to you, this informal chat. Those who early have got the benefit of that little discussion. Thank you so much, Professor.
My pleasure, my pleasure. Well,
yeah, we'll be starting in about a minute or so.
Sure.
People are continuing to join in, so we'll just...
So can I?
Yeah, yes.
I have kept my talk for just around 20 minutes. I hope we can get to learn something from Professor Way regarding the lymphedema management.
Yeah, we want to listen to you, and we want to listen to the professor also.
Yeah, sure.
Good.
No, today today is your show. I'm just here to moderate and lead a discussion.
That's very gracious of you.
Thank you. Thank you.
So our second speaker for the session for the day, Dr. Soumya, is also logged in. Good evening, Dr. Soumya.
Good evening, everybody.
Good evening. Oh, good evening.
Dr. Satish Kumar, the second session moderator. I think he's also logged in. Good evening, Dr.
Hi, good day, everyone.
Good
Hi,
day.
Dr. Karthikeyan.
Hi, how are you doing?
Good day. I'm fine. How are you?
Good, good. Nice to meet you.
Okay.
Thank you. Nice to see everyone.
So what I'm going to do now is I'm just going to make a small introduction, and then I'll hand over the session to Professor V.F. Chen. So he'll take over for the first session.
Sure.
Just give me a moment while I share my screen. So good evening, everyone. I would like to formally welcome you all to the STEP program, which is the Star Teachers in Plastic Surgery. And the motto of this program is to learn, to contribute, and to encourage the younger generation. So the episode today is season 1, episode 12, and we have two topics, two sessions. The first session will be, the topic will be our initial experience with vascularized omental flap transfer for lower limb lymphedema. The speaker would be Dr. Ramani. He has done his MCH in plastic surgery from Madras Medical College, Chennai from 2009 to 2012. And he has been a specialist resident at Tata Memorial Center, Mumbai, and international visiting scholar at the Asan Medical Center, Seoul. He is right now a consultant at Manipal Hospitals, Whitefield, Bengaluru. His fields of interest are reconstructive microsurgery, onco-reconstruction, head and neck, breast, hand trauma reconstruction, lymphedema surgery, aesthetic surgery, burns, and general plastic surgery. And We are very happy to have Professor V.F. Chen as the moderator for this session. He needs no introduction on the world stage, and he is the clinical professor of plastic surgery, the head of regional microsurgery and supermicrosurgery, the co-director, Center for Lymphedema Research and Reconstruction, and Department of Plastic and Reconstructive Surgery at the Cleveland Clinic, Ohio, USA. We welcome you, sir. Where we share our love and affection from India. And with this few words, I hand over the session of our initial experience with vascularized omental flap transfer for lower limb lymphedema to Professor. Please go ahead, sir. Yes, sir.
Okay, so I suppose I'll do a very brief introduction about the omentum lymph node transfer. So as you all know that lymphatic reconstruction has become quite popular in the recent days, and pretty much everything started from lymph node transfer, and lymph node transfer was started in around 1990. It's somewhat controversial who started it first, whether it was Professor Han-Chi Chen or Professor Karin Becker. We'll just leave it at that. Both of them started at around the same time in 1990. And so at the time, lymph node transfer was the only way to reconstruct lymphedema. Until 2000, Professor Koshima started the LVA procedure. So now we had two procedures that we can offer the patient to treat lymphedema. And since 2013 or so, after the first report of donor-site lymphedema, we realized we can cause lymphedema by taking lymph nodes. So all of us started looking throughout the body to try to find out where can we take lymph nodes safely. And so then we have various lymph nodes that were created, lymph node transfer, supraclavicular, lateral thoracic, omentum, small bowel, mesenteric lymph node. Omentum is the one that has gained the most traction. And as of today, I think looking at around the world, definitely that is the case in US for surgeons who prefer lymph node transfer or lymphatic tissue transfer. Omentum is the most popular option. So I'm very eager and curious to hear the upcoming presentation. And without further ado, let's turn the mic to our speaker.
Yeah, just yeah, thank you. Thank you, Professor Karthikeyan sir, for giving me this opportunity, and Professor Wei for accepting to moderate this session. And without saying anything, Professor Wei has given the history regarding the omental lymph node transfer. So I hope I don't have to answer those questions. Thank you. So I would like to share just our experience with free omental lymph node transfer, which we have done for purely unilateral lower limb lymphedema. And my interest with lymphedema treatment started when I had been to South Korea for the World Society for Reconstructive Microsurgery meet. And that is when we had the interest to start the treatment for lymphedema. So the center where we have done all the cases is at Manipal Hospitals, Whitefield in Bangalore. And it's a single institution experience with a duration of around 1.5 to 2 years of follow-up, where we've totally done around 4 cases of unilateral lower limb lymphedema, and 3 of them were cases of primary lymphedema, and 1 case was of secondary lymphedema. All the cases were done with laparoscopic assisted vascularized omental lymph node transfer. With regard to the workup of the patient, apart from the routine investigations, we basically do the ICG fluorescence scan and the volumetric analysis. The lymphoscintigraphy and MRI is not a routine investigation. Once we take the circumference measurement of the affected limb and the normal limb, we formulate it into a Excel sheet and then measure the volume. What is the difference between the normal limb and the affected limb? So we have the volumetric analysis, the formula which is already there, the truncated cone method, and the readings are taken at have specific intervals of say around 4 or 5 centimeters from the medial malleolus if it is the lower limb, and then it is charted into the formula. Nowadays we feel that this the world over this is being accepted as the formula to to calculate the lymphedema extremity index, which is definitely a useful measure for preoperatively and postoperatively. And then we do the indocyanin green lymphangiography. Is a routine technique where the ICG is diluted, and then it is given in the second and fourth web space. We prefer to give it over the medial aspect, and then even on the lateral aspect, posterolateral to the tendoachilles. And then in the dark room, repeated scans are done until we see the dye reaches the groin. So this is the probe, which is a near infrared LED detector, and the machine which we use. So based on the flow of the ICG, the different patterns have been classified, which is standardized. We have the linear pattern wherein we can see the lymphatic channel taking up the dye and then reaching the destination, that is the lymph node in the groin in case of a lower limb. And depending on the amount of dermal backflow, the classification as a splash or a stardust, the diffuse is taken. And this is also the management based on the ICG staging, wherein from stage 1, where you may have a linear and a splash pattern, and from stage 2 to stage 4, you have an increasing order of stardust pattern, and then in stage 5, it is all a diffuse pattern. So this treatment modality also changes, wherein as the severity increases, you can see that the elastography of the lymphatic channel, you can see that there is a increasing amount of sclerosis in the lymphatic channel. So the pumping capacity of the lymphangion is reduced. So if based on the ICG also, if you can see that in linear or in the splash pattern, you can get away by doing an LVA, and the lymphatic channel will have to pump the lymph into the veins. And as the severity increases, you see that the lymph node transfer, or in the late stages, it is going to be a liposuction and debulking procedure which is done. So the basic treatment comprises of, as Professor Wei said, that conservative management with compression and manual lymphatic drainage and complex decongestive therapy form the core of the treatment, be it before surgery and after surgery also. And with regard to surgical management, we have the lymphatic venular anastomosis and the lymph node transfer or liposuction with compression and the debulking procedures. So here I would like to share the cases which we have done and what difficulties we have faced, and what are the lessons which we have learned, and there are lots more to learn. That is what I would say. So the first case was a 26-year-old male with a history of swelling in the right leg from the age of around 10 years. When he was 10 years old, he had main complaints of swelling and occasional discharge from the foot. And then on examination, there was an edema up to the knee with minimal secondary skin changes like hypertrophy and the base of the toes. So this is his affected right limb. You can see that the swelling is there from the toes, the base of the toes, the dorsum of the foot, and up to the knee level. And this is the photo from behind, where you can see the bony landmarks are not clearly visible. The secondary skin changes are visible only here, and the skin is completely normal here except for the pitting edema. And so we did the ICG scan, which showed that the dye did not travel beyond the medial malleolus, and there was a lot of backflow, and he was into the category stage 4. So we convinced him that he would need a lymph node transfer from another site, and so as to tackle his issue. he got convinced for a laparoscopic surgery, and this is our bariatric surgeon who's harvesting the lymph node, and you can see the gastroepiploic vessels, and this is the harvest. So once the mini incision is made and the omental flap along with the lymph node and pedicle is delivered out. Yeah. So this was the flap which was removed. Though we didn't use the whole amount of flap. Here is the lymph node along with the pedicle, and this is the whole of omentum along with its vascular arcade. And so it's a two-team approach wherein the laparoscopic surgeon is doing the harvest at the abdomen side, and we at the leg end start to explore the vessels, we prefer the anterior tibial. In all the cases we have done with the anastomosis with the anterior tibial vessels, and we prepare the subcutaneous pocket, debulk the area, prepare the recipient bed, and then the anastomosis is done to the anterior tibial. The vein also is, you can see the gastroepiploic vein, the size of the vein, and for the first case we did the primary closure. This is a glove drain which was kept, and this is the tip of the flap. This was kept for monitoring purpose and to see the color of the flap basically. And I will just show a video of the harvest. So we were lucky enough to have our bariatric surgeon who's regularly doing bariatric procedures. So we clearly told him what was our requirement, and the handling of the flap is very, very important because half of the work is done by them now instead of us, because the flap harvest is being done by them. Our job is mainly to create a pocket and prepare the recipient vessel and do the anastomosis. So this becomes the main stage of the procedure. So every time being even at the leg end, you have to keep seeing what is being done in the monitor. And when they deliver the flap, we will have to keep a watch. You can see that the handling of the flap when they take it out from the abdomen. So they should not crush the pedicle or the flap tissue. Yeah, so that was the harvest, and once we did the harvest, we took it to the foot end, and this is the scan with the ICG scan machine where we give the dye intravenously after the anastomosis is done. And this is the flap which is on the dorsum of the foot on a wet mop. So once the dye is given, you can see that the dye is traveling into the arterial system and entering the flap. So immediately it gives the fluorescence. You can see your flap is perfusing well, and even the venous return can be seen. This is just to confirm the perfusion. And one more advantage with the ICG scan on table is if any part of the flap is not well perfused, then you can always discard that part of the flap. So the first case, this is how it was on table. And we had an issue with this patient. At the second day, we had put a slab to prevent any movement at the ankle. And but the patient clearly said that he had a lot of pain on the operated area. So on the second day, when we opened the dressing, we removed all the stitches. We found that there was a clot. So we had to take him to the theater the same day, and we removed all the blood clots. We found that the flap was healthy, and then since we did not do anything as such because we left the wound to heal by itself. We didn't do any grafting or secondary suturing. We left the wound to heal by itself. And we called him later at around 4 months because he was not from the local town, so he had to come from a far off distance. We did the ICG lymphangiogram at 4 months. We found that the dye was traveling into the venous system, and this is his follow-up. I'm sorry for the background because he sent it from his hometown. He is from Bangladesh. So you can see that the swelling is reduced in the leg part, though the dorsum of the foot, there is still swelling. So what we found out was even if there is some scarring or fibrosis because of the surgery, it will not give the optimum result, even if you're doing a omental transfer. The second case, she is a 56-year-old female. She had a history of around 15 years history of swelling in the right leg. She was a bank employee who was always sitting at the office hours, and her only complaint was repeated episodes of pain, swelling, and discharge in the foot. And when we did the ICG, we found that there was no clearance of the dye above the ankle, and it was a complete stardust pattern, a stage 4. Yeah, so this, she didn't have any previous surgeries in the abdomen, or she didn't have any other diseases. And when we opened up the leg, we explored the anterior tibial vessels, and then we thinned out the subcutaneous tissue. What we found was, in this lady, as soon as we put the incision, there's a lot of lymph oozing out from the incision site, and we had to debulk the tissue. But we made sure that we maintain the thickness of the skin flap on either side in order to prevent any skin necrosis. And we also made some incisions on the deep fascia. And once the flap was harvested, we have anastomosed it to the anterior tibial vessels. This is the final insert. But whatever amount of debulking you do, we will not be able to close the site primarily. That is what we saw in this case. You can see that the skin has shrunk so much here at the site where the debulking was done, but still we were not able to close. One maybe because the amount of momentum which we have used was more, or we didn't know, but we didn't want to have a compromise in the flap, so we left it open, and then we grafted the flap. So this is the flap and the insert. Sure, we had a complication again. That was a hematoma under the graft, and we lost the skin graft. We found that the flap was fine after the debridement, so we took her for a grafting at a later stage. You can see the reduction in the circumference of the leg. This was on the second week after surgery. And interestingly, she didn't come for at least 6 months after surgery, but you can see the pre-op picture, the swelling, and the post-op picture. You see that there was no wound left at all at the site where the graft was lost, except for this area. The whole leg, the swelling had reduced. We had just advised her to follow compression and massage, which the physiotherapist in our department had taught her how to do the manual lymphatic drainage. So she was just following that. And apart from that, the skin care. So she didn't have any repeated episode of lymphangitis later. She was in fact happy with the result, and she could resume her work as well. This is another case, a 52-year-old lady with swelling of the left leg for the past 10 years. And an ICG, we found that the dye could not reach the groin from the site where it was injected, even after 24 hours. So we convinced again for a laparoscopic lymph node transfer. And here it was an intraoperative difficulty which we had to face. We explored the vessels, the anterior tibial vessel, but for our luck, when we bariatric surgeon had harvested the flap, we found that the lymph node and the gastroepiploic vessels were separated from the rest of the omentum. So, but we used this as a flap, and then I'll show you in the next picture. We had a vessel, we had a pedicle in the omentum as well. So we used it as a double flap. So this is the first flap. You can see the artery and the vein done as a end-to-side anastomosis here at the ankle. And this is the omentum, because this also contains the lymphatic lakes. So we didn't want to discard that. We had a good vessel. Even though the caliber was around 0.9 to 1.2 millimeters, we did the anastomosis at the level of mid-leg, both end-to-side anastomosis. And this is how it was after the closure. Luckily, we didn't have any complication in this. This is on the third day, and this is the same patient at 2 weeks. You can see the graft is completely settled, and this is the preoperative photo, and this is the postoperative photo. The swelling is considerably reduced within 2 weeks in the leg. Up from the ankle to the knee level, the swelling is considerably reduced. This is the fourth case where we had a 32-year-old male with history of swelling in the left leg for around 10 to 12 years. But here the patient had undergone a fasciotomy for cellulitis of his foot, where he was working in Middle East. I didn't have any other details regarding that. You can see the previous fasciotomy incisions on the dorsum of the foot. Nothing, no interventions in the leg as such. But he complained of swelling on the foot and up to the leg as well, the left side. So we did the volumetric analysis. We found out that there was a significant difference of around 15% on the volume. And here, this is how we exposed the recipient area. We prefer to make such incisions on the deep fascia so that the subfacial lymphatics are being drained by the lymph node flap. And this is the picture of the harvest, the pedicle being ligated and the flap. Yeah, this is the anastomosis site here. Yeah, you can see the vein, huge in caliber. So you have to be very delicate when you handle the gastroepiploic vein and the artery. This is the final inset. We didn't close it primarily. We have put a skin graft on top of it. This is the picture after 2 weeks. He was lost for follow-up, and because of this pandemic, they are stuck in their hometown. They're not coming back for the review. So basically, the lessons what we have learned was management should always be in a comprehensive way. Like Professor Way had mentioned, it should always be with lymphatic massage and surgery as well, if and when needed. And what we found out after the start of lymphedema treatment was awareness among the clinicians. Most of the clinicians were not aware that lymphedema was treatable and who was supposed to treat it. So we found that all the cases were landing up to the Department of Vascular Surgery. And when we spoke to the others that these are the treatment options which is available, be it lymphovenous anastomosis or lymph node transfer, then that is when they started to send patients to our department, because all they knew was just debulking, excision and skin grafting. And with regard to momental lymph node transfer, all the 4 patients, we found it easy to convince them for a laparoscopic surgery, because the moment you say a lymph node transfer is needed to cure or alleviate your problem, they would definitely ask the next moment that what happens to the site from where you take the lymph node. So for us, it was easy to convince, and since the donor site morbidity is very minimum when compared to other sites, we found that momental lymph node should always be the first choice which should be offered to the patients. And it also has the advantage that it is a 2-team approach. And luckily, we had a good bariatric surgeon with us. We finished the whole procedure within 3.5 hours. And the donor site complications, what we had seen in all the patients was just prolonged ileus. But with respect to the recipient site, we have seen the complications like hematoma, graft loss, and luckily we have not seen any skin necrosis. And one more thing is the quality of life after transfer is patients are clear that their rate of infection or the inflammation in the leg, the affected leg, the episodes are very reduced after the transfer, even though we have found that the swelling of the foot takes time to reduce. Thank you.
Bravo, that was wonderful. Okay, so we will start the discussion now. How much time do we have for the discussion session?
You have another 25 minutes, sir.
25 minutes. Okay, great. So first of all, any question from the audience?
There are a few questions in the chat box.
Oh, okay. Yes, I can read the chat box. Okay.
Ramani, can you just stop sharing the screen?
Yeah, sure. 1 second. Okay, 1 second.
All right. Well, I can read off the question. Well, question from Professor GK. How far do the deep fascia incisions help in lymph drainage?
Yeah.
Question for our speaker.
Yeah. So with regard to the extremities, be it upper limb and the lower limb, what they say is that the lymphatics which are present in the above the fascia and below the fascia. When you put an incision, when you transfer a lymph node and then you make an incision in the deep fascia, the subfacial lymphatic system helps in drainage of the lymphatics into the lymph node flap. And we make incisions only at the site where we have done the debulking and the exploratory incision is done.
Okay, another question from Dr. Shashank. How many venous anastomoses were done? And also, any prerequisite of flap size or the number of lymph nodes that need to be transferred?
As far as the greater omental lymph node flap is concerned, you will have only one vein with the pedicle. And if you want to do we did one case where we did a double level. So only in one case we did 2 veins. And regarding the size, there is no prerequisite of a flap size or the number of nodes. In fact, you can palpate the nodes at the pedicle, but I don't think you will be able to count it that easily. And the flap size is, you will have to tailor it according to the patient's requirement, that is the size of the limb.
Well, that's all of the questions that I see in the chat box. Any other question from the audience? Okay, well, I will share a little bit to some comments. And I will respond to that last question about the number of lymph nodes. So for years, surgeons debated about how many lymph nodes are needed. And it's generally been assumed that more lymph nodes are better. However, there's never been any evidence. So surgeons who like, say, for example, segmental flap would say segmental flap has more lymph nodes and therefore it's better than the groin, and so on and so forth. But it's important to know that there's never been any evidence that more lymph nodes are better. And there's also never been any evidence conclusively that one flap has more lymph nodes than the other. That's the first thing. And when it comes to omentum, in addition to just the lymph nodes, there are lots of what we call the lymphoid lake or the milky spots. We know omentum is enriched in lymphatic tissue. So one idea that we need to think about, especially with now the success of lymph vessel transfer, is it the lymph node or is it the lymph vessel that's really helping? So that's an important concept. I see more question coming in. Dr. I'm sorry, I'm going to be butchering your name, Dr. Thiagarjan.
TK.
Dr. TK, okay. What happens to the skin graft in the long run? Can we excise the graft at a later date or close the defect? For moderate lymphedema, grafted leg is as bad as swollen lymphedema cosmetically. Speaker, please respond.
Yeah, so we have not excised the graft or anything like that because our follow-up has been for a very short period. I would say just 1.5 years. And you would have seen that in the second case, we had done the skin grafting for the second time, and then the whole wound shrunk to the level that we were not able to identify where the graft was. And probably we have to see whether we can excise the graft and then close the defect at a later date. I'm not sure.
So I can help with that question. So the as many of you know, we started out doing lymph node transfer a while back, and one issue that we encounter is the cosmesis. So lymph node transfer, if you want superior cosmesis, you should do a proximal transfer. So that means you put the lymph node in the groin. However, when it comes to effectiveness of the procedure, we found that distal transfer, the way our speaker performed, placing the lymph node at the ankle or at the foot, tend to work better. Patient responded better. However, then the flap become very visible. And if you have a bulky flap, if you have a heavy patient, you'll have a bulky flap, and you will have difficulty closing the wound. And we also needed to skin graft fairly frequently, because if you're forced to bury the flap, then you can cause the flap to become compromised. There's no easy solution. And later on, when the patient has decompressed, sometimes you develop sufficient skin laxity, and then you can partially bury the flap. But I think one of the drawbacks of lymph node transfer is always cosmesis. You're adding more bulk to your limb that's already bulky. To me, that is a drawback. And so one way to resolve that is to resort to other treatment options. And as many of you know, I have migrated away from lymph node transfer, even though lymph node transfer is a very effective treatment option. And when I was doing it, I was mostly happy with it. But cosmesis was also a problem that we couldn't resolve. And so, as I said, one solution is to just not do it, to do something else. Okay, I see another question from the audience. Dr. NS, what is the post-op protocol that you follow with respect to compression and MLD?
Yeah,
that's a great question.
Yeah, so with respect to compression, since most of the wound healing happens within two to 3 weeks, we start the compression after a third week. And we have not advised any of our patients to use an lymphedema stockings, but we just used only the elastic grip. And lymphatic drainage manually has been, they go to the physiotherapist, and under our guidance, we teach the patient how to milk from distal to proximal gradually, and which needs to be done at least twice a day. And we tell them that this has to be continued for at least 4 to 6 months.
Okay, another question from Dr. Sandeep. How long do you wait after an episode of lymphangitis to perform lymph node transfer?
Theoretically, I would say two to 3 weeks. We have not had the patient who came with an episode of lymphangitis, but we would say 3 weeks until the superficial infection settles with antibiotics.
Okay, from Dr. Karthik, which is a better procedure for lymphedema, omentum, lymph node transfer, or skip flap? Any studies done for this?
The procedure.
Dr. Venkat, do you want to respond?
Yeah.
So comparing skip flap and omentum. So I would say this is a little bit of they're a different category of procedures. So the skip, I'm assuming you're referring to the ultra thin skip flap. Ultra thin skip flap, excluding the deep fat layer, would be lymph vessel transfer. The full thickness skip flap is essentially a free grown flap. That's the grown lymph node transfer. So these are two different procedures comparing to the omentum transfer. Would you like to respond to that?
Yeah, we have not done basically the vascularized lymphatic vessel transfer. Okay, and we would like to do definitely, but we are looking to collect a good number of patient series for laparoscopic omental transfer or lower limb lymphedema, which we feel, as I said, being a two-team approach, we are able to give good results and finish the case faster, which is what everybody would like, both the patient and us.
Okay. Next question is actually for me. If the patient presented with lymphedema of a single lower limb, a 3-year duration with no obvious skin changes, how would you approach the patient, and how would you take a decision? If there were gross skin changes, how would you approach the patient? Okay, I think this is, so I will share with you my take on some of these cases, and the question is also relevant here. So I saw that in, I think, the first and the fourth cases presented, both patients seem to demonstrate a good amount of lymphedema-related lipodystrophy, or what we call solid predominant patient. So in these patients, their bulkiness is no longer just fluid. The bulkiness is also partially solid, or lymphedema-related lipodystrophy. I will share with you my screen. Can you see my share screen now?
Yes, sir. Yes.
Yes.
So this would be an example with a patient with early elephantiasis. So for someone like this, if we treat the patient with physiologic reconstructive procedure, whether it's LVA or lymph node transfer or lymph vessel transfer, so patient would still improve. However, the size of the leg is not expected to be significantly reduced, because the physiologic procedures are not expected to dissolve fibrosis and lipodystrophy. So for someone like this, our preference is to treat the patient with liposuction. And we would also do fasciectomy for compartment release. This is what their fascia looks like. It's always very dense, like cement. And we trim the skin with our flying squirrel technique, as many of you know. So that's the kind of result you can get on the table. And so now this patient is ready to receive a physiologic procedure. So after debulking. So this is our preference. I saw that in some of the cases presented, the patient clearly already had lymphedema, fatty tissue, and they're best treated, in my opinion, with a debulking procedure first. Okay, so it looks like next few questions are also for me. In the interest of time, I'm gonna quickly look at them, and then I will pick the ones that I felt would be probably of interest to most people. So we have a question asking, what's my flap of choice for unilateral primary lymphedema? Well, next question is the same. What's the best treatment for congenital lymphedema in children? So let me stop sharing. So the treatment, actually, our speaker, if you want to discuss about your current approach, how would you approach primary lymphedema? I think it would be of interest to all of us also, and then I can share my take.
Ramani, Dr. Ramani?
Yeah, I don't have the slides to present, but you can take over, Prof. I think that would be the best thing.
So when it comes to primary lymphedema, well, I can share with you a finding that's ahead of print. We actually haven't put this out yet. So primary lymphedema, an important concept is that it's not primary lymphedema of the leg. It's always a global hypoplasia of the entire lymphatic system. So the patient with primary lymphedema, we are quite concerned about causing lymphedema in other parts of the body. So after we made this finding, global lymphatic hypoplasia, we stopped doing lymphatic transfer procedure, whether it's lymph node transfer or lymph vessel transfer in patient with primary lymphedema. We try to treat the patient as much as is possible with LVA. And there was another question asking for our protocol. So can you see the share screen now?
Yes.
Okay, so this slide shows our protocol. So one key message is there is a procedure for lymphedema of all severity. So for stage 0 disease, we treat with preventive LVA all the way up to Charles procedure. Here you can see the lymph node transfer, even though it's still on the algorithm, we actually no longer perform lymph node transfer for the reason I just mentioned. It doesn't look very good. Many of our patients complain. In terms of effectiveness, I have no complaint about lymph node transfer. I think it works great. And usually you have very happy patient in the beginning because their lymphedema symptoms were relieved. But usually after first year, after second year, now they're used to having a relieved lymphedema condition. Now they start to look for more. They start to find the appearance bothersome. So lymph vessel transfer wouldn't have that issue. And many of you have seen our lymph vessel transfer, so I won't bother showing it. There was, let's see. So I do want to share about the evaluation. Our speaker mentioned in the beginning how they use lymphedema index and the truncated cone formula to calculate the volume. So that was also what we did initially, but since then we found something that we like a lot more, and that's 3D scanning using this app right here. So you can see on the screen, this is an app-based software that you can install on your phone or on iPad. And actually I have a video of this, but I don't have it easily that I can pull up. Essentially, you can perform a 3D scanning of the arm or leg, and you can extract circumference at any given level. And it gives you a volume. So instead of telling the patient your arm is, your affected arm is quite substantially larger than a healthy arm, you can tell the patient that your affected arm is 725 cc larger than your healthy arm. And you can observe this differential improving or worsening over time. So we found this 3D scanning app to be very, very helpful. Another tracking modality that we found really helpful is the bioimpedance, particularly the quantitative bioimpedance that can tell you how much of the bulkiness that you're seeing is fluid and how much is fat. So that's something that I think for those of you who are interested in starting lymphatic surgery, you can try looking into. We found them very helpful.
Professor, there is one question on the live YouTube screening. There is a question from Thomas Pacheco. Do you supercharge with some venous lymphatic anastomosis in the omental flap or just standard artery vein?
Is that a question for me?
I don't know. They're not.
Okay, well, our speaker, Dr. Ramani, if you want to.
No, we don't. We have not done it. We have not done it. We have just done the standard artery and vein. That's it.
So I can share with the audience that the whether it's the omentum or the jejunal mesenteric transfer, several surgeons have reported that these flaps are prone to congestion, and some have proposed ways to circumvent the problem. And this is partially due to, if you look at the blood supply to these areas, they're vascular arcades. So these are not structures that receive end blood supply. So when we perform our anastomosis, end-to-end anastomosis may put the flap at risk of venous congestion. It's not used to seeing that much blood flow. So some have suggested doing endocyte anastomosis instead, which is, well, some feel that endocyte is more physiologic, and even consider doing it as a flow through. If you take a segment of the vessel, including a branch, perfusing your omentum. If the flap is already congested, then yes, consider doing supercharging the vein. So this is a topic that have been described by people who prefer mesenteric lymph node or omentum.
So,
okay.
Would you like to sum up the session before we close the first session, Professor?
Sure. I will give a summary. So I think in general, it sounds like our speaker, Dr. Ramani, had a favorable response and favorable experience with the omentum lymph node transfer, and congratulations.
Thank you.
And I think overall it's great. We don't have enough surgeons helping this neglected patient population. And I don't know the situation in India, but in US, to do lymphedema surgery means you need to work harder, you need to get paid less. These are not money makers. They're hard to get reimbursed by insurance, but I think it's highly worthwhile, as I'm sure that Dr. Ramani has experienced. These patients are very appreciative. And I think probably the two greatest rewards of lymphedema surgery is, one, as I said, patients are very appreciative because they've been turned down, bounced around everywhere, and they couldn't find real meaningful help until they found you. That's the first gratification. The second reward is that these procedures are fun. They're technical challenge, but if you can do them and you can do them effectively, very rewarding, lots of fun. So I would invite as many of you as possible to join us in helping these patients. And there are many unanswered questions. As I said, I don't do lymph node transfer anymore, and in my opinion, lymph vessel transfer is superior. And in my opinion, lymph nodes are just there for the ride. I don't think lymph nodes are the actual therapeutic component. I think it's the lymph tissue that you have transferred that actually did the job. But, well, prove us right or prove us wrong. Join us, help these patients. Thank you.
Thank you so much, Professor. Thank you, Dr. Ramani, for a very nice talk.
Thank you.
It's interesting, and that is what this program is about, bringing out your passions into the new fields. And the professor was kind enough to share his time and his experiences with us. As he said, it may not be very financially rewarding, but the interesting part is that it is most challenging, and we all like challenges. As microsurgeons and plastic surgeons, we are interested in challenges. I suppose that should be enough impetus for us to take up this field of surgery. Thank you so much, Professor, and thank you, Ramani, once again. We'll close the first session and we'll go on to the next session. I'll just share my screen. So we go on to the next session of this program, the topic on intradermal regenerative template, expanding paradigms in reconstructive surgery. And the speaker is going to be Dr. Soumya Khanna. She has done her MCH from Christian Medical College, Vellore, from 2011 to 2014. She has been a recipient of the John Constable Traveling Scholarship in 2018 by the American Association of Plastic Surgeons, and she has visited various hospitals in US. She is right now a consultant at the Max Institute of Reconstructive Aesthetic Cleft and Craniofacial Surgery at the Max Super Specialty Hospital, Saket, New Delhi, India. Her fields of interest are aesthetic and reconstructive surgery of the breast and face, facial nerve surgery and facial reanimation procedures, lasers, facial upper and lower limb trauma and reconstruction. And the moderator for this session is going to be Professor J. Satish Kumar. a very popular person, a professor at the department, professor and head of the Department of Plastic and Reconstructive Surgery at Sri Ramachandra Institute of Higher Education and Research, Porur, Chennai. I welcome you both to this session, and without further ado, I hand over the session to Professor Satish Kumar. Please, sir.
Thank you, Professor Karthikeyan. We had an excellent first session. Thank you, Professor Chen. Thank you, Dr. Ramani. I'm sure Dr. Soumya will enthrall us with what the IDRT Integra can do as well. And even though we all like challenges, not all of us are as adventurous as Professor Karthikeyan or Professor Chen. There are some of us who are in twilight years, and we feel that it's better to be safe and do less than do more challenges. I think it's all a question of the mindset. When we are forced to, yes, we do need to do some fancy stuff. But if there are simpler options and ways to help patients with more guarantees and less morbidity, then that's something that we do look forward to, because quite a few of our patients have problems not just with the reconstruction that we can offer, but also financially. And sometimes contrary to what we believe, even though with Integra, the initial cost may be high, if you think in terms of the overall hospitalization, the time to healing, it may not always be a bad trade-off. Luckily for us, IDRT is now available in India for just over a year, even though it's been available obviously in the US and most other parts since the late 90s. So this is really an exciting field for us, what IDRT can do to help our patients. And I would hand over the session to Dr. Soumya Khanna to share her experiences with us. I look forward to her talk.
Thank you very much, Dr. Satish. Namaskaram, everybody. I think because of the time lapse, this is a better way of greeting. Congratulations. I joined Dr. Satish to congratulate the previous speakers and Dr. Chen. That was a very interesting talk, and I learned a lot from there. Yes, cost is definitely an issue in IDRT, which I shall be discussing in my presentation. So I thank Dr. Karthikeyan for giving me this opportunity to come and speak on this platform. I shall now share my screen. I hope you all can see it.
Yes.
Yes. Yeah.
Welcome, everybody. I am Dr. Soumya Khanna from Max Hospital, and I'm practicing in Delhi. So I'll be talking on intradermal regenerative template, expanding paradigms in reconstructive surgery. So I have no financial disclosures or conflict of interest. I request everybody not to take pictures to protect patient privacy. The objective of this presentation is to learn the structure and how an Integra works, when to use it in appropriate conditions, and how to get best results by using the correct method of application. So when we started off as residents, we were taught about the reconstructive ladder and the reconstructive triangle. And then later on, the concept of reconstructive elevator, because so many options were there, which was proposed by by Bennett et al. In 2000 in May. And then, when I actually joined the residency, there was this concept which was started by Dr. Janice. Because we have so many things available, there is actually, it's important to remember what to use at that point of time, which makes the best outcome for our patients. So this is the new ladder which was proposed by Dr. Janice. And, we have kind of stuck to it in our practice. Here in our hospital, the patient has to pay a lot. It is not free and thus we have to keep the finances in mind, when we actually propose our plan. So without further delay, let me go on to the IDRT. There is, it was actually developed by a very interesting story behind how it came out. It was developed by Yanis and Burke and a joint effort from China's Burn Hospital and Massachusetts Institute of Technology. They published their seminal article and how it was made and how it has been used in acute burns in 1988. And then later on, they published about the wound healing and how histologically they found it to be good. These are the few references. So there are multiple acellular dermal regenerative templates available. At present in India, we have only Integra by Dr. Reddy's lab, and BTM, which is biodegradable temporizing matrix. We haven't yet had the experience of using this. We have a good experience of using Integra in our practice because, although it is a two-stage procedure, but it gives a good response and cost-effective as well when you see in the long term. So it is actually a bilayer which is made from a thin film of silicone that limits the bacterial infection and controls the moisture. And the bottom layer is made from bovine collagen and sharp chondroitin sulfate. That actually is porous and acts like a scaffold for the new tissue regeneration in growth. So the antigenicity is actually removed by removing the telopeptidase from the bovine collagen when it is treated by a protease enzyme. So this is how it looks microscopically, the scaffold or the bovine collagen with chondroitins, and you can see how porous it is and how the tissue growth happens. This is the histology after it is healed, and you can see the collagen is well arranged, and there are few myofibroblasts, unlike hypertrophied scar and keloids. This has been approved by drug controller of India, and it has been there in Indian market for about 1.5 years only. So briefly about the indications, it can be used for chronic, acute, and for reconstructive purposes. Various types of ulcers, burns, trauma. It was initially started for burns, but then, we are kind of using in different varieties of wound, and we'll come to it later. Also used for scar revision, keloids, after tumor resections. Now, when to use and where to use totally depends upon what size of wound we are dealing, what the patient wants, what is the economics of the patients. All those factors come into play when we are deciding on applying this particular product. So before we move on, we also need to understand that this has a special advantage of actually covering the bone and the tendon, because the tissue ingrowth is laterally and not, from below upwards. So there is a creep of tissues from the edges of the wound, and then it slowly covers small areas of wound and of bone and tendons which are exposed. And you can actually gives a good strength to graft it later. So the advantages are that you get a good pinchable scar and with a good range of movement in the joint. There's a good cosmesis than the mesh skin graft. Large areas can be covered, and it is especially beneficial in children with burns or children with contractures, where you're actually hoping for a good scar which breaks less often and also doesn't hypertrophy too much. It is off the shelf, so there is low donor morbidity, and it can be used for multiple conditions. There's no chances of rejection, and definitely cost, which I'll just come over. So is it cost effective? This is something like an elephant in the room. And we do not have any Indian study. However, there is an analysis done by University of Mississippi on the impact of medical economics and the management of complex wound. They calculated the hospital bills of of patients with complications, and it could even actually went up to more than $100,000 in well-coordinated cases. However, in poorly coordinated cases, it just went quite off the mark. So, considering all that, when you want the patient to recover faster, the wound to heal, to decrease morbidity and the wound to heal faster, this is probably one thing which you can apply, and you can think that patient will will have a lesser time frame rather than being morbid, coming for dressings again and again, or maybe having not, when he or she is not fit for a free flap reconstruction. So not to have a loss is very, very, very important. And then this actually applies well when we apply the product properly with good technique. So just to show you an example of this, is about a 1.5 year old child who was referred to us with very bad contractures and of the hand. So after and she also had this scar over her breast, and the nipple the nipple was barely seen. This is actually the nipple. So the contracture were released, the scars were excised, and we decided on applying the Integra because we wanted a good quality scar here. And it is very important that that Integra is actually dipped in saline after removing it from the packet. That the buffer should be washed off well, and it should be applied edge to edge. Measure the defect well. It should be applied, as you can see here, applied at edge to edge. It comes. This is where you can see the line. This is the silicone layer which comes above, and the lower ones is the lower layer is comprised of the collagen. We always use the glue to fix it. I know there's a few thousands only, but then the surety of having a good fixation is there with the glue, because we do not want to take any chances of having a loss of Integra. And cover it with a silver dressing, preferably Acticoat. And we do apply a lot of fixation, a lot of staplers, so that there is no formation of any hematoma or any fluid. So sometimes we did not use it for this particular child, but sometimes whenever like limbs and all, we do use NPWT VAC dressing, which actually adheres the Integra very well. This is for the hand, and the dressing was done. So as you can see, this is for the next stage. You need to harvest a very thin graft. It should be so thin that you can actually see through, very, very thin. So this will actually ensure a good take. So it should be this thin. And this is when she's ready for the second stage. You lift off the silicone layer with gentle traction and irrigating, and this is how it is lifted. This is for the hand. We also irrigate it at the same time. So this is after 3 weeks. So the graft also is fixed with the glue. And a sheet graft is applied. So this is about 2 weeks after the skin grafting. So I'll also take you to the other cases that we have done. So this is a lady who presented with us with bad scars and a few contracture bands. and she wanted to, improve her cosmesis. And we excised the scars, and this is after her Integra application. So a good adherence to protocol has definitely improved our outcomes in patients. This is another indication for in a diabetic foot. This gentleman was not fit for any surgery, and we applied double layer of Integra and we fixed it with a glue. And this is a 6 months follow-up of the same gentleman, and he's not yet had a recurrence of the ulcer. We have started using Integra for small fingertip injuries, and we feel that it can be done as a OPD procedure, it can be done immediately, and generally patients are happy. This is just a 3-month follow-up of this lady. We also notice that there is ingrowth. You can see the palmar, the fingertips forming, the fingerprints forming in the regeneration, and there is generally no need to apply a skin graft because it heals. This is another patient of ours who presented with us. This was done somewhere else. He had a vulsion, and there was a with a tile in a bathroom when he slipped, and there was a necrosis of the skin. So the palmar, we didn't want a very thick. He was very, very particular about his cosmesis, and he didn't want a very thick flap or any donor side to be taken in from anywhere else. So we and also it is a palmar area where we did not want any contractures happening. So this is after his Integra. You can see that the tissue ingrowth has happened well. It has actually filled up the cavity, and this is about 2 months after, and he is actually ready for the laser without any contracture of the hand. Now, this patient actually, he's a case of post-liver transplant, and he developed mucormycosis of his abdominal wall. He was very, very sick when he was referred to us from the liver transplant unit, and we were just worried what to do. After repeated debridement, his wound kept on increasing. So once the with aggressive debridements were done, and once the fungal cultures were negative, we placed in the Integra, and 2 weeks later we put in a skin graft. We did have few areas of losses, but almost 85 to 90% of the area was covered with Integra, and then we grafted him. He actually, this was just at the time of lockdown. He actually improved, and he came out of his mucormycosis. However, he contracted coronavirus disease, and we lost this patient to the virus and not the fungus. So small things can actually destroy us without knowing that. So the other indications that we have used Integra for is for hairy nevus, wounds forming after necrotizing fasciitis with exposed tendons, morbid patients with pressure sore wounds for flaps. We have also started going to publish this. We have also started using it for after submucous fibrosis release, and we feel that the mucosal ingrowth is pretty good and applied. Fingertip injuries and few cases of keloids and hypertrophic scars. So one more usage that I found in the literature was in this article that that it can also be used as an antibiotic delivery device, wherein prior to the application of Integra, you can actually spray it with vancomycin and gentamicin, and it can be applied. And sometimes in fungal wounds, it can be applied. Amphotericin can be applied and can be placed over the wound. This actually prevents further infections. We haven't done this yet, but this is there in the literature as well. So we have done about 80 cases with various indications that I've told. And we've had one patient with full loss and 3 patients with partial loss. In the partial losses, there were no any areas of you know bone or tendon exposure, so they could be skin grafted over 6 years. So the complications are, as I said before, a good fixation, a good anchoring will actually prevent hematoma or seroma formation and a good take of the integra. Infections can be prevented by having a good debridement. Clinically, if the wound is looking good, there will always be some growth, but if clinically you have a good granulation tissue and it's free of slough, most of the time integra does well. Do send in a culture prior to application, and use good fixation and good antibiotic cover. A frequent inspection after the integra application is very, very important, because if there are pockets wherein you find that it is not taken well means that it should be peachy orangish color after the take. That happens, that color start coming in after a week of application. So if you're not finding and you're finding pus, just incise the silastic layer and drain out the pus, irrigate it well, and just leave it there, and do more frequent change of dressing. Call the patient and keep inspecting. And if that area it doesn't take, it's all right, but rest of the area it should not be spreading. This will actually prevent poor take of integra. Premature silicone separation happens if you've not fixed it well, or if it is in the mobile area and you've not immobilized the area. This again, I came across in the literature that there is one patient which has reported toxic shock syndrome after integra application, but we haven't seen any other cases like that. So in conclusion, it's always better to give the best to our patients even if it is a scar, and definitely an early recovery would be welcomed by everybody. It is surely a good tool in our armamentarium, and we feel that, as the time goes by, we can work around the cost once the usage increases and the patients understand them well. The cost in what is there offered in United States and in India is definitely different. It is much cheaper in India compared to US. In children, we definitely feel that it's a good option because the scar is much, much better. And especially in burns, they recover faster with less donor site. It also buys us time, for the donor site to grow. If there are large areas, you can just leave the silicone layer on, partly cover it with skin graft, and then, come back a week later when the skin grows again, because you're taking a very thin graft here. And it is easy to use, good cosmetic result even in fingertips, and a meticulous fixation and adherence to sterility can help us in a good graft take. So I thank you all for giving for patient hearing. This is my team, and this is our department head, Dr. Chaudhary, Dr. Raghav, and Dr. Prateek. I work with them, and it's a pleasure to be in this department. Thank you very much. I can take the questions now.
Thank you, Dr. Soumya. That was a very interesting and clear talk. I think there are a few questions coming through. One is from Dr. Karthikeyan himself. He wants to know, one day, can we do away with all flap covers? And do you think there are some wounds that we cannot use integra on?
Sir, I do not think flap cover will go any days anyway. Usage, as I said before, this is just one of the ways that we have. We have to use it well. And nowadays, the patients who come to us, they are very well read. There are patients who are not wanting a donor site. There are patients in larger areas where you need where you need a good cover. There is no substitute to a flap. But if there are small areas, there are small wounds wherein you think that Integra will do without giving any donor site morbidity, definitely it's a good option which you can offer to the patient if the patient is ready to take it.
Thank you. I think to answer Dr. Karthikeyan's question a little bit more, not to worry, we still need a plastic surgeon to do this. And there is still a place for microsurgery, especially when you want to lift your flap, be able to do further work underneath. Even though this provides great cover, it's like a full thickness graft. It's sort of intermediate between a full thickness graft and maybe a flap characteristics. But one thing you can't do is to lift it and work underneath. So your orthopedic surgeon will not thank you even if you get this area covered with Integra. If he wants to do subsequently bone grafting, or he wants to remove the X-fix and slide a plate underneath, Integra would not permit that. So you will steal flap covers in those situations. So all is not lost. And if you have an amputation, you're not going to put that. Maybe for a fingertip, yes. But if you have to do anything slightly more proximal, you would need a replant or a revas as opposed to just covering it with Integra. I think the thing to fear is perhaps these stem cells. I do not want to live to see the day when you have an amputated arm or a brachial plexus and you can sprinkle some magic powder or stem cells in it and everything starts working again. That will really be the death knell for our specialty. But till that day comes, I think we have a role to play.
Yeah, flaps will never go out of fashion.
Yeah, thank heavens for that. Okay, the next question again is from Dr. Karthikeyan. How long has been your follow-up of these patients, and was there any skin graft contracture?
The contracture is always there, but the percentage of contracture is much lesser compared to if we just put in a skin graft. So what you give is a good scar which is pinchable, which we do not get in a plain skin graft. So yes, we do have a follow-up of about, we have been using, like, since in this department, I have seen for about 6 years. This has been there in India for about a year and a half. So previously we used to get it imported from outside. The patients used to get it. So over the 6 years, the scar quality is definitely better compared to, the other skin graft. So it is a good, you can say about 4 years follow-up we do have few patients. But yes, you see, how our patients follow up. It's difficult to trace them back.
Sure. Yeah, I think as she very rightly said, if you were to compare it without Integra, you saw the kind of skin graft that she applied with exceedingly thin. And nowadays there are people who like a little bit of dermis, a touch of dermis on the undersurface of the epidermis. So initially the plan was to use thin epidermal autografts, but now we feel that a little bit of dermis is useful when you take the silicone layer off. But if you compare what your donor site is, absolutely thin dermatome house graft, and you see the amount of elasticity in the area which has been treated with Integra, absolutely no comparison. It's obviously not as great as a flap, but if you think in terms of what the patient is giving up, which is basically a thinnish SSG, and you see the quality of the scar, it really makes it worthwhile. The next question is from Professor T.C. Chandran, one of our senior and foremost plastic surgeons have. And sir has asked, how is it useful in scar revision?
So the first case that I showed in my presentation was actually, there was no contracture, but it was a bad scar in the forearm. Do you want me to show it again? So in large scar, large areas, where there is undulations, uneven surfaces, when the patient is wanting a little better improvement, in such patients, it's a good option to have a, not for small scars, but for large areas with irregularities, it can be used. It does give a good result.
I think if you can't get a primary closure or maybe a tissue expansion, then this is slightly better. Obviously, you don't get the dermal appendages back, but it at least doesn't have any mottling and irregularities as opposed to a regular scar, or maybe if you have a meshed graft, those kind of areas, the variegated appearance can certainly be improved. The next question is from Dr. George. He wants to know what's the actual cost.
So it comes in different sizes. The smallest size is about 5 into 5 centimeter, which costs about 24,000, 24 to 25,000. And this is the minimum price. The biggest size is about 10 into 25, 4 into 25 inches. So that is somewhere nearly 3 lakhs or something. But most of the time, you have to measure your wound well, your defect well, to know how much to order. There is a way of doing that. So you calculate the surface area and you divide by the sheet. So the sizes are available online. You can check out the things. This is just the range that I'm telling you.
Sure.
And you can divide it and you can calculate the approximate area and order the sheet accordingly.
Yeah. Well, another question that I have, just to add on, when you're using it for fingertips, the smallest size, as you said, is 2 by 2. What do you do with the rest?
Sir, it was actually, we do not use it again for the next patient. So the patient buys it and gives it to us. Or if we have to order it, it comes in the patient's bill. So we explain them the cost and all, and they are ready to tell them all the options. So.
Sure. Okay. The next question.
Especially the kids, the parents are very, very, they're very interested in doing this because they do not want any other donor site with the kid. Sure. So they are ready to bear the cost.
Okay. The next question is from Dr. Shashank. Any experience of using Integra in chronic wounds like venous ulcers?
Venous ulcers, no. We have used it for diabetic foot ulcers for sure. In chronic wounds who have come from outs, it can be used. There is an indication for that. I haven't used per se. But if you have a long-standing exposed, few areas of exposed tendon, we actually debride the wound well and then put a vac for some time, and then once the wound is granulated a bit, and there you feel that there's not too much tendons exposed, and we do explain this option of flap and Integra, and if the patient takes it, it's fine. That's the usual approach. We have seen such patients who have come post venous ulcers, then having a necrotizing fasciitis, and then in such patients we have covered. Not like direct venous ulcer, we haven't used, but it can be used.
Sure. The next is from Dr. Karthik, who appreciates the presentation and wants to know, can it be used to cover small areas of exposed metal implant?
No, it cannot be used. We have never used, we will not try also. It's not, I don't think it will work.
Yeah. Okay. The problem would be that even if it's a small area, as you very rightly said, no one has used it, because once you want to do further procedures to take out that implant, or if the fracture doesn't heal, this Integra template would not allow you to do further work. And in those situations where you want good vascularity to help combat infections and to minimize risk, this at the end of the day is still an implant and has the risk of getting infected in itself, which a flap will not have. So when you have vascularized tissue, it could deliver antibiotics, white cells, your whole immune components can be brought in, and Integra does not have that ability. So as you very rightly said, that would not be a great choice. The next question is from Dr. Kamal Kumar. Role of integra in acute burns after tangential excision.
Yes, this has been described actually in literature. It can be done. And there are a lot of images also available if you read the literature.
Okay.
This is very well indicated. And in fact, it actually decreases the morbidity of the child very well. I mean, sorry, of the patient. It may not be child also, because it gives an immediate cover without, prevents losses, and you don't have to skin graft it immediately. You optimize the patient and then you graft it well, and you can do it in stages.
Okay, right. Professor Kamal, if I could add on to that, this is how Integra started. In the initial stages, it was for coverage of major burns after tangential excision, and the other indications that we've discussed all through today were added much later. So in 96, when Integra was first used overseas outside UK, the first area it started being used was in Britain, and that was in a burns unit. And what was done at that particular point was to cover areas with Integra, and meanwhile send a small skin excision sample for cultured keratinocytes growth. So this was sent, and in the few weeks that it would take for the keratinocytes to get cultured, the integra would get vascularized, and when it came to removal of the silicon outer layer, the keratinocytes either in cell suspension or as a sheet was available for cover. And this used to be the best way to salvage people with literally 90-95% burns. So most of those situations, if there wasn't a significant component of smoke inhalations, those people could be saved. The problem that was noted at a later point in time was the fact that even though the cultured keratinocytes helped heal the wound, even over integra, it wasn't a very stable cover. The epidermis wasn't adherent enough onto the integra template that they started having blisters and areas of repeated breakdown, which is why cultured keratinocytes have gone out of favor in all parts of the world, and people still want to harvest thin grafts with a little bit of the dermis as well to try and use on the second stage of the operation once the silicone sheet is removed. So going on to the next question. This is from Dr. Shantakumar. He wants to know how much maximum area of bare bone can be covered with integra.
It depends upon the quality of the tissues around, but I wouldn't say more than centimeter or two. It's like if you have a bone peeping out, you can take this chance of applying. But you have a big bone raw area, I don't think you should think twice and do a flap. You should not put an integra if you have a bigger bone which is dry and desiccated.
Okay. You can add on to that. It also depends on the kind of bone that is exposed. If it's a membranous bone like the scalp, so even if there's no periosteum on it, you could perhaps cover it. And it depends on whether it's intraoperatively created clean wound or whether you're thinking in terms of a wound where there's been a history of trauma or infection. So you've got to differentiate. Basically, integra will not bring dead tissue back to life. So if that bone is devitalized, then you might have to shingle it or burn down the outer layers till you get some amount of vascularity in it. And if it's an extremity bone, even maybe more than a few millimeters would be hard pressed to get covered with integra. But if it's, for example, the scalp, even larger areas of exposed bone could technically be covered. In those situations, you'll have to wait for much longer. The 2 or 3 weeks deadline for vascularization is not a hard and fast rule. You basically have to make sure that the entire thickness of the integra is vascularized and the silicone layer is easy to peel off. If it's not fully vascularized and that peachy cream color has not been achieved, then you're better off continuing with dressings till the integra is fully vascularized, the color changes, and the silicone, you can even do a sort of, when they come for the dressings, you can try in one little corner to see whether the silicone layer peels off easily. If it's peeling off, that's perhaps an indication that the integra is vascularized and the patient is ready for skin cover. But as far as exposed bone and tendon goes, I think it's a little bit like the size of the perforator and what area of flap can technically be harvested based on that perforator. You would not have an exact answer, but people are tending to cover larger and larger areas of exposed bone or tendon with integra, but we still don't know the perfect answer to that question as to what is the amount of area that integra can bridge. We know for a skin graft that it's a few millimeters. With integra, it's more, but exactly what that width is, we are not too sure. Obviously, if you have intervening spaces where there's a possibility for the integra to get vascularized and then bridge over, then it will do well. But if it's a single sheet, we still do not know the ultimate answer to that question.
May I add
Yeah.
one more
Yes,
thing?
please.
There are literature describing scalp wound cover after burring and integra application. But yes, it does take time. And recently, people have even reconstructed eye socket also with the application of integra.
Yeah, very true. So if it's a membranous bone, you have a little bit more leeway than if it's an extremity. Right. The next question is from Dr. Balakrishnan. Any experience with skin allograft in burns in children?
Good evening, sir. We don't have, sir. We have used Integra, but not the Alloderm. And I do not Alloderm. The same company, they have come up with a substitute like that, but we haven't used Alloderm for burns in children.
Okay, this is regarding skin allografts. Skin allografts in children with burns.
No, sir, we haven't used. Thank you.
Sure. I think questions wise, that's about it. Any further comments, questions? Professor Karthikeyan?
I was just asking if you could sum up before we close the session, because
sure. Okay. I think that was a very interesting presentation, and the advantage we have, as far as I see it, Integra as was being presented, Integra has the ability, sometimes even flap, we could technically use a flap, but for example, many cases when we see our groin flaps for finger injuries, degloving, we actually wonder and wish that this patient hadn't come to us and they had gone elsewhere, because our ultimate results are so bulky. So if you want exceedingly thin cover, sometimes Integra does much better than the super thin flaps even that we can offer. And if you offer such flaps, we might need further debulking. And many times we've seen people with groin flaps covering thumbs who say it looks quite unsightly. Could I even have the digit amputated? So those kind of issues, and small multiple areas. If you have a flap, you'll need one confluent area, flaps do well. But if you have small areas of tendon exposure here and there, like an entire lower extremity that's been degloved, and you have small pockets, Integra does really well in those situations. And you did mention about negative pressure therapy. That again is a useful adjunct along with the silver dressings, because infection is one thing that Integra will succumb easily to, in addition to making sure that you have good hemostasis and you have a nice healthy bed. If you could use maybe a silver dressing and a negative pressure therapy, which improves the vascularity of the bed and literally seals the area, the bed vascularity being better, you have a shorter duration before you can actually take the silicone layer down and proceed with it. One word of caution though, when you apply negative pressure wound therapy, the entire bed tends to shrink in a little bit. So you have to make a little bit of allowance for that when you're insetting the integra, and treat this like a full thickness graft. When you're placing the integra, as Dr. Khanna was mentioning, you have to respect it and treat it exactly like FDSG and not overlap on the edges like you would for a split skin graft. And never ever take the silicone sheet off and leave it exposed, because that will be an area where the integra desiccates and will be lost. And if there are areas where the integra gets infected or rejected, it's all is not lost. Other areas may take, and in those areas, if still needed, you could add on more integra sheets as well. So that area also, if you really want the benefit of integra, certain areas that are lost, you could again place a further integra sheet, wait for it to vascularize, and then cover it. So it really helps us in tricky situations. And obviously, people who do not want too much morbidity from a donor site, it's really of use. And hopefully, if the economics of production and transport make sure that the rates come down, I'm sure more people can benefit from these procedures. Thank you very much, Dr. Khanna. Thank you, Dr. Karthikeyan. I don't think we've, okay, I think there's one more question that's come up from Professor Almil Lu. Can
we store the integra?
Okay. Can integra be stored in a sterile atmosphere for use in the same patient?
We do store it, but we have not yet got a chance to, because it actually, it is only for one-time use. Ideally, you're not supposed to, because it starts disintegrating. So we do keep it, but we've never used it again for the same patient.
Okay. Okay. Technically, I think they say the company would not stand by you if you were to use it later because of the risk of infection once it's contaminated. It has a shelf life of about 2 years. So in certain situations, if you have a large sheet and you only need a small bit for a patient, there is an option of, I think some people have done it, get an integra sheet, maybe divide it into the 2 patients that they need it for, tell patients that they're going to share it with another person, and then after cutting it, take it to an adjacent OT where it can be used. So that I know has been done in a few situations, but once you opened it, you technically cannot use it at a later point in time because of sterility issues.
Okay, Professor
Right.
Satish, thank you.
Thanks, everyone. Thanks for a very interesting day, Dr. Karthik.
Yeah, thank you. So today, another episode of STEP program where we have introduced 2 speakers and 2 topics on which we are very curious. All of us are very curious. One was this lymphedema, the omental flap for lymphedema surgery, how it is done and what are the results. And the second was the role of integra. It seems to be so promising. And we all know it is expensive, but it was nice of both Dr. Ramani and Dr. Soumya to elaborate on these 2 topics. And it was more interesting, and we are very thankful to Professor V and Professor Satish, who have contributed their experience in these fields and sort of made the session very lively and interesting. Thanks, sir. Thank you, both of you, and both the speakers and both the moderators. We shall meet you again next week with another interesting 2 topics by 2 young plastic surgeons. Thank you very much, and good evening, good night.
Thank you. Thank you, sir.
Thanks, everyone. Thank you. Bye-bye.